Okay, good afternoon, esteemed colleagues. Welcome to the fourth session of the Hematology Grand Round, jointly organized by the leading house of Iran North America Academic Partnership and Research Institute of Oncology, Hematology, and Cell Therapy. I am Dr. Marjan Yaghmaie, Professor of Medical Genetics and Director of International Affairs at Tehran University of Medical Sciences. Today's session is focused on highly critical and evolving area of hematology, advances in molecular classification of AML and MDS, and MRD surveillance for patients with AML. It's a great honor to introduce our distinguished speaker, Dr. Sanam Loghavi. Sanam is an associate professor of pathology and laboratory medicine at Department of Hematopathology at MD Anderson Cancer Center. She is board certified in hematopathology and molecular pathology and specializes in hematologic malignancies, particularly in myeloid malignancies. Her research interests include molecular risk stratification of hematologic malignancies and measurable residual disease detection. She has authored over 240 peer-reviewed publications on hematologic malignancies and is co-investigator on several national and international run clinical trials for heme malignancies. She is the editor-in-chief of the American Society of Hematology Image Bank. Okay, without further delay, please join me in welcoming Dr. Loghavi for her presentation. And please feel free to post your question in the chat box. We will address them at the end of the presentation during the Q&A session. Dr. Loghavi, please.
Thank you very much for the kind introduction, Dr. Yaghmaie. It's a pleasure and an honor to be here with you today. Thank you very much for this invitation. And without further delay, I'm just going to start the presentation, which, as you said, is on advances in molecular classification of AML and MDS and MRD surveillance for acute myeloid leukemia. So as you all are aware, in 2022, the classification of myeloid malignancies, well, the entire classification of hematolymphoid malignancies, including myeloid malignancies, was revamped. And we were provided with the 5th edition of the WHO classification and also a novel classification, the International Consensus Classification, which were both published around the same time in 2022. I'll start a little bit with the classification of MDS, and then I think that I'm going to spend a lot of more time on AML throughout the presentation, but I did want to touch upon MDS as well for a little bit. So if you think about the hierarchy of the classification of MDS, and this really includes both the ICC and the WHO as I have them here on the two left-hand columns, the classification is branched really at two essential time points. One is if you have molecular determinants of disease, then you classify the disease by its molecular alterations. But then if you don't have molecularly defining disease features, then you revert back to morphology. So what are the molecular defining events in MDS? One is MDS with low blast and 5q deletion. Despite what the name implies here, you're allowed up to one additional cytogenetic abnormality as long as it's not involving chromosome 7 or 7q, the long arm of 7q. MDS with low blast and SF3B1 mutation, of course, as the name implies, has SF3B1 mutation, but the WHO does allow for inclusion of cases where the status of SF3B1 is unknown, or if SF3B1 is wild type, but you have more than 15% ring sideroblasts. There's been a lot of debate on this inclusion, and I really do believe that in future iterations, this is probably going to get revised because, you know, we know that other of course, MDS types can present with ring sideroblasts, but they won't necessarily be responsive to luspatercept. And the most important thing about MDS with SF3B1 is that it's highly responsive to luspatercept. And then MDS with biallelic TP53 inactivation or MDS with mutated TP53 are cases that have less than 20% blasts and include a multi-hit alteration in TP53. And I'll go into a little bit more detail on that in the next slide. And then if you don't have any of these categories, you revert back to morphology and essentially classify the case based on the presence of increased blasts and fibrosis and hypoplastic MDS, which are recognized by WHO only and not by ICC. So what is the story with, the allelic status of TP53 and MDS, and how did this become all of a sudden so important? This was really a fortuitous finding that Elsa Bernard and Elie Papa-Manuel and the IWG team came across when they were working on the IPSSM paper and classification, where they noticed that patients with MDS that had one mutation in TP53 really had both hematologic parameters and outcomes in terms of their overall survival and leukemia-free survival that were comparable to patients that had wild-type TP53. However, the outcome of patients that had MDS with either two mutations in TP53 or a mutation and deletion of the other allele on 17p or mutation with copy neutral loss of heterozygosity of TP53, those patients did extremely poorly in terms of their outcomes. And this is how the entire concept of MDS with biallelic TP53 was introduced in the field. And so, just to go back to the biology of TP53 and why we think this is important, as you know, TP53 is a tumor suppressor gene. So oftentimes in the process of malignancies, when you have an alteration in a tumor suppressor gene, if you have one preserved wild type allele, to some extent, it can still compensate for the mutated allele. But once you have loss of both of your wild type alleles, then that's when the catastrophic event happens and you get really bad outcomes. So similarly here, where nobody is doing single cell sequencing in clinical practice, so we really have no way of knowing whether something is truly biallelic or not. However, based on the biology that I just described and what we know about TP53, we assume that when there's two mutations, the mutations involve two different alleles. Of course, when you have one mutation and the other allele is deleted, that's pretty straightforward. I think where most laboratories, well, not most, but some laboratories have trouble is determining when there's copy neutral loss of heterozygosity, because our routine assays don't really look for copy neutral loss of heterozygosity. And so what happens is we use variant allele frequency as a surrogate. And when the variant allele frequency is more than 40 or 50%, you kind of infer that there's copy neutral loss of heterozygosity. So this is how TP53 mutated MDS is defined. And here's an example just to show you some morphology. This is a case with multilineage dysplasia with a dysplastic megakaryocyte here, as noted by the arrow. And then on the aspirate smears, you can see erythroid and neutrophilic dysplasia. This case has a complex karyotype, including a derivative chromosome of 517 that leads to loss of TP53. And here on the IHC stain, you can see that there's aberrant overexpression of P53. I do want to note that we use this stain very routinely and frequently, both in the setting of MDS and AML. And it's a really great surrogate marker for determining the presence of a mutation, but it's not good for determining the allelic status. So you can say that there's a mutation there, usually when you see aberrant overexpression. And by that, I mean really what's the really intensely dark staining 3+ pattern. That's thought to be abnormal, usually correlates with missense mutations. And then there's another pattern that I'm not showing you here, but it's complete absence of staining. That is also abnormal and typically correlates with either nonsense or early frameshift mutations that lead to the antibody just not recognizing the epitope. One thing that I want to note here is I'm sure you probably come across this question in your practice, and we come across this question now frequently, with frequency, is that patients present with what is thought to be clonal hematopoiesis that is incidentally discovered on either germline testing or testing for another solid tumor, where the patient has a P53 mutation, may or may not be cytopenic, so it may be clonal hematopoiesis or CCUS. And then we're asked to do a bone marrow and say whether there's MDS or not. So of course, the definition, by definition, the difference between clonal hematopoiesis and CCUS and MDS is the presence or absence of dysplasia. But one of the things that I find very helpful in our practice is that in cases with clonal hematopoiesis or CCUS, even if you have a high variant allele frequency, as I'm showing you in the case of this patient that has a VAF of 34%, the P53 staining pattern in clonal hematopoiesis before the disease has transformed to actual MDS still has a normal staining pattern. And we find this very helpful. All right, so we talked about SF3B1 mutations and, they're essentially class-defining feature for MDS. I do want to point out this is a publication that we have in press right now in Blood Cancer Discovery, led by Curtis Lakowitz at Oregon Health University. And we really show one of the features of, because if you remember the classification, the WHO imposes a 5% variant allele frequency for SF3B1, and the ICC imposes a 10% variant allele frequency for SF3B1 to make this diagnosis. And we tried to look at this cutoff of 10%, both looking at, just the numerical cutoff of VAF and also looking at cases that had subclonal SF3B1 to another dominant mutation. And just to summarize for you, there is really a difference between the genetic landscape of these cases. So patients that have low VAF SF3B1 or subclonal SF3B1 tend to have higher frequencies of high-risk mutations like ASXL1 and SRSF2, and also tend to have higher IPSSM risk stratification. So important to know the burden of disease in SF3B1 clonal MDS. And then also this was shown to be impactful in terms of leukemia-free survival, both when you look at the cutoff of 10%, so SF3B1 high versus low, and also when you look at clonality, with STAG2 and RUNX1 mutations being independently associated with worse outcomes in the setting of SF3B1 mutations. All right, so with that, I'll move on to acute myeloid leukemia, because I think, that's pretty much the extent of genetic classification for now for MDS, but I'm sure that'll evolve in the upcoming issues. So for AML, the vast majority of AML, I can tell you probably 90% of the cases that I look at now in my practice can be genetically defined. There remains a very small subset of cases that we're unable to genetically define, and we define by differentiation as indicated by WHO. But the vast majority of the cases are genetically defined, and the genetically defining lesions are the ones that I'm listing here for you on this slide. One of the things that is important and is a discrepancy between the two systems is the numerical blast threshold that is recommended for making a diagnosis of AML in the presence of these genetic abnormalities. So the WHO, with the exception of CEBPA and BCR-ABL, where they require more than 20% blasts, for all the other genetically defining categories, they use a 5% blast category. So you don't need 20% blast anymore. If you have 5% blast with any one of these genetic abnormalities, including a KMT2A rearrangement or an NPM1 mutation, by definition, you have acute myeloid leukemia. So you don't need more than 5%, you don't need more than 20% blast. However, the ICC, for all of pretty much their categories, including CBPA, they require a 10% blast threshold at this point. And I think I can show you some convincing data that at least for some of these, really there should be no blast threshold imposed at all. And I'll show you a little bit of that data. So in the United States, since April 2017, and actually the menin inhibitors were added after this, so there's been a several number of FDA approvals for targeted therapy for acute myeloid leukemia, largely based on the presence of molecular drivers of disease, such as IDH inhibitors, FLT3 inhibitors, and of course, now the menin inhibitors for NPM1 and KMT2A rearranged leukemia is, of course, only being approved for KMT2A at this time, but investigational for NPM1. So based on really the therapy being determined by the presence or absence of these genetic alterations, how do we work up a new AML at this time, at a center like mine? Of course, we do a morphologic review to still get a blast count. We still do cytochemical stains for MPO and NSE. It's very fast, it's cheap, and it tells us whether something's myeloid or not. We run a very preliminary scatter of CD45, 34, and 19, which we see on the same day, which we use mostly to triage the case to see what other molecular testing needs to be done based on whether it's going to be a myeloid leukemia or a lymphoid leukemia. And then we have the full flow panel ready next day with the phenotype ready to report. We're doing a routine karyotype on all of our cases. The turnaround time for routine karyotype here is about 3 to 8 days, depending on how proliferative the disease is. We do same-day FISH for PML RARA, core binding factor beta, so in version 16, KMT2A rearrangement, RUNX1, RUNX1T1, and then BCR-ABL1 and NUP98 are added as necessary. We don't necessarily do them routinely, but the other ones are done routinely for all newly diagnosed AML. And then we add additional FISH as needed. The turnaround time for those is variable. And we also do optical genome mapping on all of our newly diagnosed myeloid neoplasms at this time to really look for other cryptic and less evident cytogenetic abnormalities that may be missed on a routine karyotype. In terms of molecular diagnostics, we have a standalone FLT3 assay. The FLT3 assay is standalone for two reasons. One is the bioinformatic pipelines for NGS really have difficulty picking up, especially the longer ITDs in FLT3. So we run a capillary electrophoresis, and also because the turnaround time is very critical for FLT3 because it determines the therapeutic approach that they're going to take. And so the clinicians want to know the results faster. And then our NGS panel is an 81 gene panel. We're able to report on 11 genes in this panel within 2 days. And these 11 are those that are actionable either therapeutically or diagnostically very critical, such as JAK2 or MIPL or calreticulin for MPNs. And then our full NGS panel is reported out in about 3 to 5 days. We also run a RNA-based translocation panel that looks for recurrent or other rare fusions. It's really agnostic of the partner, and then other tests variable as necessary. So if you look at the ELN classification and risk stratification for acute myeloid leukemia at this time, there's really two ways to risk stratify patients. So the ELN 2022 applies to younger adults that are treated with high intensity chemotherapy regimens. The favorable risk group are the core binding factor leukemias, NPM1 mutated AML without FLT3 ITD, and then CBPA with mutations in the BZIP region. So if you recall, the previous iteration of the ELN had biallelic CBPA mutations as being favorable, but this has now been changed to any mutation. It can be a single mutation as long as it's in the BZIP region of the gene. Intermediate risk is NPM1 with FLT3 ITD. Any FLT3 ITD without adverse cytogenetics or molecular features, and then KMT2A specifically rearranged to MLLT3. So that's also intermediate. And then the other KMT2A rearranged and several other genetic abnormalities such as the DEC-NUP214, BCR-ABL1, MECOM, complex karyotype, monosomal karyotype are considered adverse. And the ELN 2022 introduced this new category of myelodysplasia-related genes as being adverse in the ELN 2022, except for if they co-occur with favorable genetics. So if you have MR mutations with any of these favorable genetics, it's not considered adverse. Otherwise, it is considered adverse. And then there was a revised ELN for patients that are receiving less intensive therapies, including those that are receiving HMA ven-based, so venetoclax-based therapies. And here it's really a 5-gene classifier, whereas mutated NPM1 in the absence of RAS and FLT3 and TP53 is favorable. Same for IDH2 and IDH1. If they don't occur with these adverse ones, they're considered favorable, largely due to the effect of IDH inhibitors in this patient group. And then mutated DDX41, because we know these patients respond incredibly well to HMA ven-based therapy. And then other cytogenetic abnormalities that are not FLT3, NRAS, or TP53 mutated, KRAS or TP53 mutated. And then the only adverse risk category in the setting of low intensity therapy is mutated TP53, and then everything else is considered to be intermediate risk. So I want to talk a little bit about the emerging role of menin inhibition. So these are our newest class of therapies that are widely under investigation at this time, but the menin inhibitor revumenib, so the Syndax menin inhibitor, was approved last year for KMT2A rearranged acute leukemias, and then everything else is still currently under investigation. So the genotypes that are thought to respond to menin inhibition are NPM1 NPM1 mutated AMLs, KMT2A rearranged AMLs, and then NUP98, and other rare genetic abnormalities that lead to HOX upregulation. And here's, a schematic showing the interaction of KMT2A with menin and how disruption of this interaction leads to reversal of leukemogenesis and differentiation of the leukemic blasts. So how do we recognize these leukemias? Because again, it's critical for us to give the clinicians a heads up that this is going to be a leukemia that may respond to menin inhibition. So the NPM1 mutated AMLs have characteristic morphologic features, including these cup-like blasts with the invagination in the nuclei that resembles the opening of a cup. And they also typically have fairly distinct phenotypes, the most common being an APL-like phenotype that is CD34 negative, CD117 positive, and HLA-DR negative. And then also commonly they can be myelomonocytic. So those are fairly characteristic. If I see something that has these cup-like blasts with one of those two phenotypes, I can be fairly confident that I'm dealing with an NPM1 mutated AML. That said, we do also have an NPM1 IHC that really is, I have to say, one of my favorite stains to work with because it's highly sensitive and highly specific, which is not always the case for, IHC stains. But in this case, I'm showing you a mutant pattern in the top right panel and a wild type pattern in the bottom right. And the difference here is that so NPM1 is ubiquitously expressed by every cell in the body, but the normal localization is to the nucleus. When you have a mutation, the aberrant protein or the mutated protein gets dislocated to the cytoplasm. And so the localization of the staining is able to tell us there's a mutation when you have cytoplasmic and nuclear staining, but then the wild type should really be restricted to the nuclei with really these nice spaces between the nuclei. And this IHC is very good. It picks up all of the NPM1 mutations. And in fact, it also picks up NPM1 rearrangements. And I'll show you an example of that. And then for KMT2A rearranged, we know that these are often monoblastic leukemias that present with very high white blood cell counts. In adults particularly, I do want to point out that in children, which KMT2A is one of the more frequent genetic abnormalities in pediatric leukemias, these can be megakaryoblast, as the picture that I'm showing you here in this frame. So that's one other thing to think about when you see megakaryoblast leukemias in pediatric populations. And then finally, I want to talk a little bit about NUP98 because these, again, are very susceptible to menin inhibition, but their recognition is somewhat problematic because they're cryptic. And so here's an example of a NUP98 rearranged acute leukemia. You can see on the karyotype, while there is abnormalities, it doesn't really involve the NUP98 locus, and I'll show you a little bit more detail on that. But I do want to point out that if you're not specifically looking for NUP98 rearrangements, and of course, you're not going to see them by karyotype, whenever you see a case, particularly in a younger adult that has a concurrent FLT3 ITD and a WT1 mutation, in the absence of other leukemia-driving genetics such as NPM1 or KMT2A, you really should be thinking about the presence of NUP98. And if you have a FISH panel or a FISH probe, you should be fishing for it. In our case, because we do optical genome mapping, it's really easy now to see these NUP98 rearrangements. And so as you can see here, there's a three-way translocation involving chromosomes 2, 22, and 19, which is what we saw on the original karyotype. But there's also a cryptic 511 translocation that leads to the most common NUP98 fusion protein, which is the NSD1 NUP98. So again, this case would be amenable to menin inhibition. And we did do a large, I guess, relatively large study on both de novo and relapse refractory AML using OGM. And about 48% of the cases, we were able to either identify clinically relevant and important alterations or identify fusion partners that would otherwise not be identifiable on routine karyotype or break apart FISH probes. And so some of these included therapeutically actionable genes, including KMT2A rearrangement and NUP98 rearrangement. Sorry, one more slide on NPM1. Here's another case that again has an NPM1 fusion that was identified by OGM. What I do want to point out here is the abnormal pattern of staining, or the mutant pattern of staining by IHC, which was puzzling to us in the beginning when we diagnosed this case, because you had this abnormal pattern, but the NGS came back as negative for a mutation. But then, of course, when we saw the results of the OGM, you realize that there's an NPM1 fusion that also leads to the same cytoplasmic dislocation and probably should be leukemia defining, just like NPM1 mutations. But at this point, it is not in the current classification system. All right, so a little bit about the significance of blast count in the less than 20% blast count in NPM1 mutated AMLs. There's been several studies. I'm just showing you two here as, three here as examples, but several studies had shown that patients with NPM1 mutations and less than 20% blasts do better if they're treated with intensive AML type therapies compared to MDS type therapies. But then, again, as I showed you in the beginning, there's a disagreement between the WHO and the ICC as to where to draw the blast percentage cutoff. And ICC uses 10% and NPM1 uses, WHO uses 5%. So why does this matter? Of course it matters because, at least at a center like ours, trial eligibility and enrollment depends on the diagnosis that you put on the pathology report. So let's say if I have a case that has less than 10% blast or less than 5% blast with an NPM1 mutation, with our current guidelines, I am unable to render a definitive diagnosis of AML. And of course matters for MRD assessments. I'm not sure how reimbursements work in Iran at the time, but for us right now, especially reimbursement for molecular or flow cytometric MRD, meaning, if whether or not the insurance pays for the test, it really depends on the indication. And if you don't give a diagnosis of AML in the beginning, MRD assessment becomes very challenging throughout the course of surveillance. So that's why it matters. So with that in mind, we said, can we look and see whether there's a difference between the 5%, the 10%, or 20% blast thresholds? And again, this paper is in press in Blood Cancer Discovery. And really, just to summarize the features for you, there's absolutely no difference between the molecular landscape of cases with less than 10% blasts with those more than 10% blasts. So they have the same molecular features. And if you look at survival, the survivals are the same whether you use a 5%, 5 to 9%, or 10% blast threshold, with actually numerically the less than 5% blast category being the worst group, because these patients probably received less intensive therapies throughout the course of their disease. And really, when you look at by multivariate analysis, in patients that have NPM1 mutation and less than 20% blast, whatever cutoff you use, the only thing that matters is the patient's age, so a 60-year-old age cutoff, and whether or not the patients were treated with intensive therapy. So I think this is pretty good proof that tells us that, patients with NPM1 mutations, regardless of their blast count, should be diagnosed and designated as acute myeloid leukemia. I did review this briefly in a few slides prior to this, but I do want to highlight that, in the ELN, the MR mutations are adverse unless they occur with a favorable risk genetic. And we did, there's been several studies with conflicting results looking at particularly the combination of MR mutations and NPM1 mutations, with some studies showing the presence of MR mutations confers adverse risk, but then other studies showing that there's absolutely no difference in survival. And of course, I think if you read into the details of these studies, there's patients in this, on the left-hand side, nobody received venetoclax. In the study in the middle, patients received venetoclax. So there's some, treatment differences, but again, the results were conflicting. So we also did look at this in the in Curtis's paper, in the Blood Cancer Discovery paper, but before that, I just want to point out that this is a paper actually that we published a couple years ago from the Emmy Anderson group, showing just looking at splicing factor mutations, so not the other MR mutations. So this was only splicing factor mutations, where we showed that if you add venetoclax, the addition of venetoclax really does mitigate the prognostic impact of these MR mutations. So perhaps in the setting of venetoclax therapy, they shouldn't really be regarded as adverse, particularly if they occur with NPM1. And then finally, if you don't have any of these genetically defining features, the WHO at least recommends that you define the AML by differentiation. And I want to show you a little bit of data of why I think this is really important. And not only in the absence of genetic features, but even if you have genetically defining features, I think it's good to designate what type of phenotype the leukemia has, whether or not it's monocytic or erythroid or megakaryoblastic particularly, because there's, first of all, there's data that shows some of these genetic alterations, particularly in the setting of acute erythroid leukemia or pure erythroid leukemia, as it was, designated before, but now the WHO only recognizes this as an acute erythroid leukemia, and the ICC really doesn't recognize it at all as any form of erythroid leukemia, and just calls it TP53 mutated AML by virtue of most of these cases having biallelic or multi-hit TP53 mutations. And here's an example, showing you an acute erythroid leukemia. Here you can see the CD71 staining very intensely and uniformly, signifying erythroid differentiation, and the P53 IHC showing a normal abnormal pattern of staining, and of course the beautiful erythroid morphology that we see here. But again, as I said, in the ICC, this is not recognized as a distinct category of disease because the presence of TP53 mutations supersede the erythroid differentiation. However, there is very nice data from several independent laboratories showing that both erythroid and megakaryocytic and monocytic differentiation confer BCL-XL dependency and venetoclax resistance. So I think it's still important to designate in our reports whether or not there's monocytic, erythroid, or megakaryoblastic differentiation. And I'm just showing you here a picture of Dr. Bennett. For those of you that are familiar with him, he is the founder of the FAB, or the French American British classification system. And I think the FAB, even though we don't formally use it anymore, it really does have value. And I'm a huge proponent of including phenotypic information in the classification of AML. Okay, so finally, I want to talk a little bit about MRD. I know that the audience was interested in hearing more about MRD. I do want to point out that even with all of our, targeted therapies and advances in the classification and therapy of acute myeloid leukemia, it still remains one of the deadliest cancers in, in the world, with a survival rate of less than 5%, or sorry, less than 30% for 5-year overall survival rate. So one of the things that has consistently been shown to be prognostically important in the setting of acute myeloid leukemia is measurable residual disease. What exactly is measurable residual disease? It really depends on what assay or test we're talking about. And here I'm showing you really a schematic to drive this point home, is because the more sensitive of an assay you use, of course, the definition of MRD becomes different, and we'll talk a little bit about these MRD definitions. But at this point, regardless of the method that you use, so this is a nice paper by Nick Short that was published in JAMA Oncology 2020, where he looked at essentially every single paper that was published on MRD and combined the data and showed that, regardless of the method, whether you're looking at molecular or flow cytometric MRD, patients that achieve MRD negativity have better overall survivals and disease-free survivals compared to those that MRD positivity. And I think this is, very intuitive. It's not groundbreaking, of course. This is logical, right? But how do we actually apply this in clinical practice? Is there a difference between the various molecular markers of MRD? And I think the field is largely evolving in this really designation and classification, but I'm going to try and show you some data to at least what is now recommended and being used. So in 2017, the ELN formally recognized MRD negative CR as a response endpoint in AML. So before this, really MRD negative CR was not a recognized endpoint, but as of 2017, it is, right? Sorry. So really, baseline risk stratification, the ELN risk stratifications that we talked about, at this time, it's recommended to adjust the baseline risk stratification based on MRD status. So if we think about the ELN, for example, let's think about the ELN 2022. So for high intensity, according to ELN 2022, if you have a FLT3 ITD at baseline, that patient's considered to be intermediate risk and is potentially eligible to receive a hematopoietic stem cell transplant. And of course, if you have adverse, then there's no question the patient really should be transplanted. But then the question in the field that I think really has now been answered is, if you achieve MRD negativity, do you still need a transplant or not? And I think in the setting of NPM1, the answer is very clear now that you really don't need a transplant if you have an NPM1 mutated patient with or without FLT3 ITD that achieves NPM1 MRD negativity. So, but how do we define that MRD? I think we'll see in the next slides. That's a very important question. So if we think about AML pathogenesis, we really go from, it's not this straightforward, but I think this is a nice schematic that shows the leukemogenesis process. Is you go from a molecularly simple landscape of clonal hematopoiesis to acquisition of additional driver mutations, some of which are leukemia defining, such as NPM1, and then you kind of evolve into full-blown leukemia, right? So what does AML therapy do? It really reverses this clonal trajectory. So oftentimes you'll see that, for instance, in patients with NPM1, therapy will eradicate the NPM1 mutated clone, but you will see persistence of MDS type or CHIP type mutations in the surveillance samples. So does that matter or not? I think, again, thinking about the methods that we use, you really have to think about this in two buckets. One is, what is the method you're using? What is it detecting? And then the other is, depending on the abnormality that you are detecting as MRD, are those actionable or potentially prognostic or not? So for us right now, the methods that we're using, of course, is FISH, which is really not an MRD method because the sensitivity is only about 1%. It's of course only useful for genetic abnormalities that are present at baseline, so only applicable in about 50% of AML. And you have to know what you're looking for, right? So you have to know the baseline abnormality. Flow cytometry is great because you don't have to know the baseline. You really can use a deviation from normal approach. This, of course, does have its own challenges and diagnostic, I think, complexities, because, as I said, you can get rid of the AML clone, but have persistent clonal hematopoiesis or MDS type changes that may, show alterations that may be difficult to interpret by flow cytometry. But again, the sensitivity is great, and it's really applicable to more than 90% of AML because more than 90% have abnormal phenotype at baseline. PCR, so RT-PCR with a sensitivity of 10 to the minus 4, 10 to the minus 6 is great, but you really have to know what you're looking for. Most laboratories in the US use RT-PCR for core binding factor leukemias as well as NPM1. And of course, this is an RNA-based assay. And then next generation sequencing, I think this deserves a little bit more in-depth discussion, because the majority of our clinical grade next generation sequencing panels are not error corrected, and their sensitivity is about 10 to the minus 2 at best. But for MRD, you really need a sensitivity of 10 to the minus 4. And so if you're going to use NGS, you need to use error-corrected NGS, which allows you to subtract the background noise of PCR to achieve this 10 to the minus 4 sensitivity. And this is just a little bit about error correction in NGS. For maybe some of our molecular colleagues that may be listening to this, this lecture, is really what you do is you use unique molecular identifiers to tag your your amplicons, and then based on these unique molecular identifiers, you can identify whether a sequencing error is a false positive error, because if it's a false positive and a product of PCR, the unique molecular identifier will also be the same. Whereas if you have a true positive, the unique molecular identifier should not be the same. And so you can use this approach to correct for PCR error. And again, the definitions for MRD response, I've just listed this here for reference for you. I don't want to really go through the details in the interest of time, but just to show you that there's such thing as low-level molecular relapse if you're using high sensitivity methods such as NPM1, qPCR, or error-corrected NGS. But of course, the recommendation here is that when you have molecular MRD relapse, you really want to confirm this on 2 consecutive samples, preferably using bone marrow, and preferably showing a log increase in the level of MRD to make sure that you're actually dealing with truly positive MRD. So in terms of molecular markers, how are the panels designed? One is targeted panels to assess for mutations that were present at baseline. I don't think really anybody is doing this at this point because it's a very non-efficient approach if you're trying to design panels that are patient specific. The other one that most laboratories are using is mutation agnostic panels, where you just look for a large set of genes, regardless of whether they were present at baseline or not. But of course, all mutations are not the same. Everything is considered a potential MRD, but we know there are definitive markers of MRD, such as NPM1. And then there are other mutations, such as the DTAs or clonal hematopoiesis mutations, which we know are actually not informative for MRD. So if you have persistence of DTAs, there is no correlation with outcome. And then other non-DTA mutations we'll talk a little bit about. I think there's a lot of variation on how to interpret these depending on the specific type of mutation. So here's just as a reference, the study in the New England Journal of Medicine that showed that persistence of DTA mutations does not inform outcomes, but anything other than DTA, when you combine NGS and flow cytometry, of course, patients that have both positive are the ones that have the highest rate of relapse. The ones that have one positive and the other one negative fall somewhere in between. And of course, if you clear MRD by both methods, then those patients are the ones that have the best outcomes. I do want to talk a little bit about this concept of residual clonal hematopoiesis in the setting of MRD, and we looked at this a few years ago in our MD Anderson patients. And you can see that you can have either persistent clonal hematopoiesis or emerging, so newly identifiable clonal hematopoiesis mutations after therapy. And these 2 bar graphs that I'm showing you here, really the point that I want to drive here is that while the NPM1 mutation goes away with therapy, you can see that the IDH2 and DNMT3A here in this patient example just persist throughout the course of therapy, including when the patient got CLIA and nivolumab. But the only way you can eradicate these mutations is really with an allogeneic hematopoietic stem cell transplant. But the question is really, does the patient need a transplant to eradicate these mutations or not? And this is very controversial, and I think still a gap in the field with respect to different mutations. But again, there are chip-like mutations. I think that the most comprehensive study that I know of is from the German group here, dividing the mutations into chip-like mutations and CHOP-like mutations. So chip-like mutations are DNMT3A, TET2, SRSF2, and IDH2, and these do not seem to impact outcome if they persist after therapy, but then every other mutation does, with various degrees of impact. So everything else, apart from these chip-like mutations, should really be considered as persistence of MRD. We have, back in 2019, we had a paper from the MD Anderson group where we showed that really the persistence of IDH1 and IDH2 in remission was associated with relapse if you had combined IDH and flow cytometric evidence of MRD. That was really where it was most impactful. And then subsequent to that, there's another really nice paper by Chris Hurrigan's group where they looked at a large number of patients with mutated IDH1 before allogeneic stem cell transplant. And in this cohort, if the patients cleared, for the patients that had NPM1 and FLT3 ITD mutations as well, if they cleared the NPM1 and or FLT3 ITD, the persistence of IDH1 had absolutely no impact on outcomes. So I think, this is very telling that in the setting of at least IDH, persistence of molecular IDH really does not matter. And so these are, again, for your reference, I'm not going to walk through this, but at this time, the MRD markers that are recommended for testing in ELN are NPM1, core binding factor AMLs, APL, and then for everything else, you really use flow cytometry. I think subsequent to this, there is data. Again, this is just reiterating what I just said, so I'm going to skip over this in the interest of time. But the reason ELN 2017 did not include FLT3 as a marker of MRD was really based on studies showing that FLT3, as I'm showing you here, FLT3 mutations can often be subclonal in the setting of AML. And so the thinking here was that because of their subclonal nature, the absence of FLT3 may not be informative. In other words, it doesn't have a good negative predictive value. But of course, if you have persistence of FLT3, that is a very good indicator that you have residual disease. So I think with that, the logic and knowledge, the ELN decided to leave FLT3 out largely to avoid false negative results. But then there are several studies, including the quantum study, the gilteritinib study, all of the FLT3 inhibitor studies showing that the benefit of receiving post-allogeneic hematopoietic stem cell transplant maintenance with FLT3 really is in the patients that have persistent MRD. And so this became very important, and also showing that, again, by Chris Hurrigan's group, in the pre-measure study, FLT3 was a very robust and powerful marker of MRD. So if you had FLT3 ITD positivity, there was no doubt that the outcomes, both relapse-free survival and overall free survival, were much worse. And the same is true when you have NPM1 and FLT3 together. So clearance of both mutations seems to be the most impactful. And in the setting of NPM1 and FLT3, because NPM1 is typically the founder clone, NPM1 negativity tends to be more prognostic and impactful. And at least in this study, they showed that flow cytometry had absolutely no distinguishing power in terms of negative versus positive for outcome. So it's really the status of NPM1 and FLT3 that you need to know. I see this every day now with our practice, is because we use an error-corrected NGS for NPM1 and FLT3, and it is actually more common than not to see a negative flow result with a positive NGS result, because the NGS is just, by 1 to 2 logs more sensitive than the flow. So it's no surprise to me that flow cytometry was not helpful in distinguishing outcomes. Again, here's another study showing the impact of FLT3. So I have no doubt that in the next iteration of the ELN for MRD recommendations, FLT3 ITD will definitely be included as a marker of MRD. And again, this is one final study by Jad Othman at King's College that was published last year. I think this is a seminal study, again, referring to the prognostic impact of NPM1 and really changing the baseline risk stratification for patients, is that allogeneic hematopoietic stem cell transplant in CR1 was only beneficial to patients that had NPM1 MRD positivity in CR1. So if you did not have residual NPM1, there's no reason to transplant the patients. And so this is a review paper that we published last year, really summarizing everything that is present at this time in terms of recommendations for MRD testing and how to incorporate those into practice. So again, the AML MRD markers really that we think at this time are highly prognostic are NPM1, FLT3 ITD, core binding factor AMLs, and then for everything else, because we just don't have good assays to look for them, we're using flow cytometry. And then the recommended timing is listed here, and I can share these slides with everyone after the lecture is over. And of course, I can, just from what I see in practice is sometimes you'll see very low level emerging molecular markers of MRD like NPM1 and FLT3. And I think in those cases, the recommendation, again, to just agree and reiterate what the ELN 22 guidelines say is to repeat the testing in a short window of time, maybe 2 to 4 weeks, to make sure that it's actually a true positive result. And then finally, with that, I want to show an example. We talk a lot about MRD positivity and how molecular is the be-all and end-all and the definitive answer. But I do want to say that molecular is not perfect either, and it really depends on the context of therapy. So here's a patient with a newly diagnosed NPM1 IDH2 mutated AML that's receiving so HMA, ven, and enasidenib, which is an IDH2 inhibitor, so a differentiating type therapy. And so this patient receives therapy. This is their this is the follow-up sample. Here you can see that there's differentiation. This does not look like an acute leukemia, right? You can look at this and say this patient, at least morphologically, is in remission. And then if I show you the flow plots at baseline on the top and compared to MRD, this is the blast population here. This gray population with a typical NPM1 mutated HLA-DR negative 117 positive phenotype that's positive for 123. If I look at flow MRD on the post-remission sample, this area is really empty. You don't see anything that resembles the original blast here. But then if you look at the NGS results, there's residual NPM1. So this VRF, if you convert this to variant allele frequency, is equivalent to 37%. So there's a 37% VAF mutation here by NGS. So what is going on? Does this patient actually have residual disease or not? And if you look at the NGS NPM1 in isolation, you could interpret this as residual disease. But then knowing the status of the flow and knowing that this is an adequate sample, so no problem with sample adequacy, if I go back and do an NPM1 IHC on this case, you can actually see that some of the cells with cytoplasmic staining are the cells that are differentiating. You can see their indented nuclei. So this is really a pattern that I think we should be familiar with, particularly helpful in NPM1, of course, because you can see, you can use the stain to see the localization of the cytoplasmic staining. But again, to be aware of this differentiation concept where, you don't want to take the patients off therapy by just saying, oh, they're not responding to the therapy. This is similar to what we see in APL. And if you do a bone marrow in a few weeks or next cycle, this MRD will have been cleared because this is just differentiation. And so in conclusion, I think, there's no doubt that MRD is highly prognostic, regardless of the method that you use. I think I didn't really go over the details of flow, but the way we're approaching flow cytometry right now is we use a deviation from normal approach. If the cells are very aberrant, I think Marjan was asking me if you don't have the baseline molecular, if you don't have the baseline phenotype, I think it depends on the degree of aberrancy. If the cells are very aberrant, we still tend to err on the side of calling them AML. But there are, we actually have a paper in the British Journal of Hematology in, I believe it's 2021, where we looked at this phenomenon of, the flow cytometric findings in clonal hematopoiesis and post-remission clonal hematopoiesis. Those abnormalities tend to be fairly subtle. So if you just have some decrease in 38, some increase in 123 or 117, those can really be residual clonal hematopoiesis and not AML. Of course, we know that, the impact of the different mutations is different. So at this time, really, the mutations that we recommend to use are NPM1 and FLT3 ITD, and of course, the core binding factor AMLs, with everything else really not being that prognostic. And then important to avoid over-interpreting AML MRD, especially as MRD-directed therapies become available in the context of clinical trials. And the last thing that we showed, be aware of the pitfalls of molecular MRD assessment in the setting of using differentiating agents, and this actually includes menin inhibitors as well. And with that, I'll be happy to take any questions.
Thank you, Dr. Loghavi, for that insightful and thought-provoking presentation. And we now open the floor for questions. I think we have 2 questions in the chat box. I also have some questions too.
Sure.
Okay, the
Yeah, so I
first
see the questions.
Yeah, one question is Dr. Ashrafi. You can also read the question, Sanam, if you like, or I can
Sure.
also.
So they say, yeah, go ahead. Why don't you go ahead?
Okay. Dr. Ashrafi asked, in a case of AML with inversion 16 and trisomy 13, how would you classify the patient risk? So I think it's a straightforward
Favorable.
question.
Yeah,
Yeah,
favorable.
yeah, okay. And the other question is from Seema. Thank you for your great presentation. I was wondering if you have started using a spectral flow cytometry in AML MRD setting or overall in routine immunophenotyping evaluation.
No, we're not. It's still research-based. Spectral flow cytometry is still research. We're not using it in clinical practice.
Okay. Sanam, I have one question regarding a CBF AML that we evaluated for the MRD by RQ-PCR, and we have 3-log reduction. Okay, but by NGS we have MRD positive by FLT3 and by FLT3. It means that, as you mentioned, for the CBF AML with MRD negative, we can exclude from the allotransplant. But regarding this case, I would like to see if we only have one platform for the RQ-PCR or CBF, and it was MRD negative, but we also checked by NGS and found that the patient is positive for FLT3. Should we also consider this patient again as a favorable risk and exclude from allotransplant, or we should consider the
Is this ITD? Is that an ITD?
Yes, ITD.
Yes, ITD. Yeah, I think that they are, I would consider that patient for a transplant. So yeah, because it may have actually been in independent clones as well, right? But if you have residual FLT3 ITD, I think you have residual AML.
So it means that it's better that we use multi-platform for MRD, because as ELN mentioned that for CBF AML we can also use the RQ-PCR is only enough, but I think for some cases like that we may miss some.
I think if you have FLT3, yeah, if you have a concurrent FLT3, and this is what we do as well, it's always good to test for both.
Okay, and also for NPM1 fusion, that's from a case that you mentioned. And also, I would like to see if the NPM1 mutation is negative, do we always need to check the NPM1 fusion as well?
If you see IHC that looks abnormal, yes. But in general, they're very rare. They're not common. But if you see an IHC pattern that suggests that there's a mutation and you don't have a mutation, then I would check for fusion.
Okay, and if we use
but they're not that common, very rare.
Okay, and if we have more than one platform, or if we check more than one platform for MRD evaluation, and there is some discordancy between these 2 techniques, we should always rely on the MRD positivity. I mean that, for example, we have a patient in relapse, which the IDH1 is positive, and the patient is on IDH1 inhibitors, and the IDH1 by NGS is negative. By multicolor flow cytometry, the MRD is positive. So we should consider the multicolor flow cytometry MRD positivity according to continue the treatment, or the IDH1 by NGS is negative.
Yeah, I think flow is challenging. It's difficult. I don't want to just give one answer, because I think, depending on the type of aberrancy you're seeing, if it's really an aberrant phenotype, I would go with the flow. But I think if it's subtle abnormalities that may be just reflective of a persistent, not the IDH, but another concurrent clonal hematopoiesis type mutation, I would not interpret that as MRD. So I think that really depends on a case-by-case, basis, and looking at the specific phenotype, comparing it with the original. But if it's the same phenotype as the original leukemia, yeah, I would count that as MRD positivity. Because remember, flow is much more sensitive than non-error corrected NGS. Right? So flow goes 10 to the -4, NGS is 10 to the -2.
Okay. Any other question? Let's see. Dr. Aghbegi, do you have one question or not? I cannot see any question in the chat box.
All right.
Okay, I think there is no other question. Thank you for your insightful presentation. On behalf of the leading house of Iran and North America, Academic Partnership, and Tehran University of Medical Sciences, and the International Affairs of TUMS, I sincerely thank Dr. Loghavi for sharing her expertise with us today. This presentation highlighted the critical role of molecular and MRD-guided approaches in the evolving landscape of AML and MDS management, and we hope it inspires continued innovation and collaboration in this vital field. Thank you all who attended this meeting, and please stay connected with us for the future Grand Round and educational programs. Wishing you a productive day ahead. Thank you, Sanam.
Thank you so much for having me. It was a pleasure. Thank you.
Okay, thank you. Bye-bye.
Bye.
Bye.